recovery and treatment, opioid recovery and treatment here in Juneau-Gastineau Rotary. And today is April 22nd, 2021. So Dolores, I'll let you go ahead and take it away. I think you can share your screen if you'd like to.
That's okay. Actually, what I'll do more than anything else is just talk initially. I do have one thing I will share, but thank you very much to everybody. And I do want to clarify something because I think Julie Olson is insinuating that she only sees me very late at night. I don't think that's true, okay? So basically, I moved to Juneau back in 2019 with my husband from Boca Raton, Florida. And I accepted a job in Juneau working with individuals who suffer from substance use disorder. My background had been trauma and ER in South Florida. I worked in a very, very busy emergency room in Fort Lauderdale. We saw about 300 patients per day coming through our ER, and a huge majority of those patients suffered from substance use disorder and co-occurring mental health disorders as well. So I moved up to Juneau to work for a company who specializes in substance use disorder and what is medication-assisted treatment. So if we look at our patients who suffer from high blood pressure or diabetes, there have been medications around for high blood pressure since 1896, which is one of the first medications that came out. Up until about the year 2002, we've had absolutely no medications at all to assist individuals who are suffering from substance use disorder. And in 2002, a medication came out. That medication is called, the generic name is buprenorphine, and the brand names are either Subutex or Suboxone. And now we have a way that we can actually treat individuals who suffer from substance use disorder, things like heroin or opiates or pills. And of course, we're seeing so much influx of opiates into the United States in the last 10 or 15 years, and individuals are suffering really badly, but we now have a medication that can treat them. And that medication is Suboxone or Subutex. So one of the reasons why individuals up to this point were not really that successful is because when an individual goes through withdrawals from an opiate, okay, the withdrawals are very, very severe, and that's what this particular medication does. Suboxone started out as a medication for pain relief, but people can't get high on it. There's a thing called a ceiling effect to that medication, and individuals can't get high on Suboxone, so it helps with cravings, it helps with withdrawals, and we help get people into treatment so they're not using medications. It's the same thing with high blood pressure. You start individuals on a blood pressure medication and then hopefully work on diet, exercise, other things that might actually improve their blood pressures. But if I don't give them a blood pressure medication, that person may end up having a stroke, heart attack, and die. And we can't treat a dead person, okay? It's the same thing as well with Suboxone, okay? What we would like to do with these individuals is start them on a medication, treat the withdrawals and cravings, get to a point where their brains are healing and they've been in sobriety a certain amount of time, normally about a year when we start tapering individuals off medication, but we don't have to taper them off the same way as I wouldn't withdraw a person's blood pressure or diabetic medication just because they've got to an optimal number, for example. So it's the same thing with Suboxone. What happened with us was, of course, in 2019, we were hit with the pandemic. And since 2019, the situation has just gotten 1,000 times worse. The initial numbers came out from the CDC reporting that through August of 2020, overdose deaths were approximately 81,000, which was a massive increase over the same time frame the year before. The CDC has now gone ahead March of this year and revised that number. It's looking like overdose deaths from opiates is going to be around about the 90,000 mark. And part of the problem with the pandemic is that individuals were in economic shock. We live in Juneau, okay? We also have an office in Ketchikan. My patients in Juneau and Ketchikan have not had a paycheck since October of 2019. Okay, so because they rely heavily on tourism and the ships coming in and everything, the last ships came in to both places in 2019, and individuals have not had jobs, have not had a paycheck, are suffering from economic shock. In addition to that, they have mental health stress. How am I going to feed my children? Individuals are now at home in their houses with their children at home, having to homeschool them. One of the biggest problems as well is that everybody is isolated. We are humans by nature. Bees build hives, humans build tribes. So individuals are sitting at home, they're isolated. And then also as well, another huge problem is that there was lack of access to any services. The entire 12-step program, NA and AA, went completely online March of last year because they couldn't have in-person meetings. And in addition to that, the inpatient treatment facilities that would take very, very acutely ill and chronically ill individuals, those treatment facilities all throughout Alaska, everywhere, okay, but in Alaska as well, those treatment facilities shut down and wouldn't accept individuals because they had to put into effect pandemic mitigation strategies. So where you would have 16-bed inpatient facilities, they were now only be able to accept maybe 3 or 4 people. Okay, so it cut down access to services. In addition to that, it cut down access to services to counselors. And this problem is only going to worsen. I will tell you that in Juneau, the problem is extremely bad. We have a lot more room for people to get into medication-assisted treatment services. People are not availing of those services in the numbers that we would, of course, like them to do. And then the other problem is as well, is that within the last 6 months, we have had an absolutely horrific influx into Washington. I telemed into Washington every day as well, but we've had a horrific influx of fentanyl, which is 1,000 times more potent than morphine and than heroin, okay? And it's extremely cheap, okay? It's coming in, it's manufactured in China, and then it's been coming in through the border with Mexico. As we've released, unfortunately, and as we've released the southern border of Mexico, now all of these drugs are coming in with much more frequency. I don't know what has happened in the last week. Our toxicology, we were not seeing an awful lot of fentanyl in Juneau or Ketchikan or Anchorage. Within the last week, 10 days, nearly every single toxicology report that we're getting in on our patients is positive for fentanyl. I do know in Juneau, and these are hard facts, and these are only my patients, I do know of, since Thursday of last week, so a week ago today, I do know of 4 near fatal overdoses, and this is just my own patients, okay? Fentanyl was tied to all of that toxicology. I do know that the problem is there, and it's evident in Kenai. It is evident and positive in our toxicology in patients in Anchorage and in Fairbanks. Fairbanks, not so much. It hasn't actually gotten up as far as Fairbanks yet, but it's only a matter of another week or two. And we're also seeing manufactured or what we call pressed Xanax or Xanny bars, and also Mexies, Percocet 30s, Blues. These are the pills and stuff that are being found on the street, and individuals are buying. This is they're fake Percocet 30s or Blues, and those are coming in from Mexico. And the lethality rate is horrible. It only takes a tiny little bit of fentanyl for an individual to overdose. So where my patients have been using a 0.5 gram to 1 gram of heroin, people are actually overdosing on 1/10 of a gram if it's containing fentanyl. So this is a huge problem, and we're only going, this is the tip of the iceberg today. We're only going to see this problem worsen. Ideal Option, the company that I work for, we have partnered with DHSS with a thing called Project Hope. We actually provide Narcan kits to our patients. I'm actually looking for one here, sorry. So we provide Narcan kits to patients. These Narcan kits are available at the Ideal Options office. I do know that Front Street Clinic has them, Jammy has them as well. And these kits contain 2 Narcans. And that buys an individual time, okay, or a parent or a partner or a loved one, that buys them time to reverse an opiate overdose. And basically, we do ask or request that individuals, if they're using a Narcan kit, that they actually call 911, because you can, fentanyl, in terms of its half-life, you can have a secondary overdose with fentanyl. So last but not least, I mean, where do we go from here? We need to get individuals access to service. Back in February, the governor, or the state of Alaska rather, let the emergency declaration expire. So this no longer allows Alaskans access to start treatment without an in-person, face-to-face meeting. So up throughout the pandemic, the emergency declaration covered providers like myself, and we were allowed to see patients all over the state of Alaska, Nome, Bethel. I actually have a patient that I saw in Ukavik, and we started those individuals on Suboxone, on this particular medication. And a lot of these patients have had no access to treatment prior to this, okay? But because of the reversal of the emergency order back in February, we can no longer do that. The individual or the patient has to meet face-to-face with a provider. So that means that people in the state of Alaska can't get access to service in a timely fashion. Unfortunately, with substance use disorder, what you have to meet the patient where they are. When an individual is ready to get into treatment, that's when you have to be able to see them and provide service. To tell an individual, well, you need to fly from Nome to a provider in Anchorage is not reasonable. You know, it just doesn't work for this patient population, unfortunately. So we've been working with and following House Bill 76, which is looking at the emergency declaration order and putting that emergency declaration order back in place. The good news is that with the latest changes to that bill, they're looking at, instead of extending the bill through September 30th of this year, they're looking at extending it through December 31st of this year, which will give us 3 more months to actually work with the state of Alaska to change the requirements. So the problem is worsening in Juneau. If you know anybody, they can just walk into my office, Ideal Option. They can go to Front Street, they can go to Jammy, they can pick up these kits, the Narcan Project Hope kits. It's all anonymous. We just give out the kits. All we do is we take some demographics to know, no names, nothing like that. It's all anonymous, but anybody can walk in and get it. So that's what I do.
Right, thank you. Do we have any questions from the group? Annette?
Thank you for what you do. The question that I have done some reading on Narcan, and a lot of first responders say that it has made many addicts more aggressive about taking their drugs because now they know they have a safety outlet. Do you find that to be true? Thank you.
Absolutely not at all. Not at all. I don't find, and even seeing patients, I don't find any patient or family member or individual who says, you know, there's a safety net out there. I'll just, you know, take my drugs, use my drugs, and I know that there's a reversal agent. Because as well, what we're finding with the fentanyl, unfortunately, and that's what most of the heroin supply now is going to be adulterated with, what we're finding is that it's actually not even taking 2 Narcan to reverse that overdose. We're finding that it's taking at least 4 Narcan, and even sometimes with that, it's not reversing the overdose. I do know for a fact that we've used this with the homeless population. We've had multiple drug reversals downtown Juneau. My husband has done CPR on a patient, used Narcan kits, done CPR, waited for fire rescue to get there. The individual was shocked and the individual lived. I do know of another patient as well in Kenai over the weekend, exact same scenario. Thankfully, she had a kit at home. Her husband recognized it, used it on her, The 2 Narcan did not work on her. He started CPR on her, fire rescue arrived, and she was shocked as well. But I don't think there's anybody out there who's, I have not seen it. You know, I think it's kind of a misnomer about our patient population that they do that. I will say, when you use Narcan on an individual, they do become aggressive because it throws the patient into immediate withdrawal. It's very uncomfortable. It's horrible. So, so they do become aggressive and coming out of the opiate overdose when you use Narcan. But I don't think there's a patient, unless they're intentionally. There are individuals, if it's an intentional overdose and they're trying, they don't want Narcan around because they don't want it to be reversed.
Hey, this is Dan. I have a question, June. Thank you for what you do. You said Juno's problem was getting worse, and it sounds like it got worse in the last 10 days. And so as far as like getting worse now, is that additional people in Juno who live here who are becoming addicted, or are we importing people? I'm just curious if our numbers are going up, are they?
I think when I say the problem is worsening, I mean that those individuals that are currently using heroin are now faced with an even, and I had a discussion with a patient about this yesterday. It seems that, so for example, fentanyl is really, really potent even when it's smoked. So I was trying to figure out with a patient yesterday that it seems to even be disproportionately affecting chronic heroin users in our community. Okay, and the thing is that you just, heroin is and substance use disorder is completely non-selective. You know, one of the good things, if there is anything good about the pandemic, is that those individuals who don't want to come into a place or an office that is medication assisted treatment had access to coming in to see us via telemedicine and via Zoom, etc. And what that opened up the doors to is an awful lot of professional individuals now seeking help because of the anonymity. They didn't have to walk into an office. So what we were seeing was that an awful lot of, you know, lawyers, doctors, dentists, etc., people who had, you know, full-time jobs, just happened to have a substance use disorder problem, were now seeking access to treatment. But the problem with fentanyl right now at the moment, and the worsening problem in Juno, is up until this point we had heroin, which was individuals knew their tolerance, they knew their limit, they knew how much they could inject, and now all of a sudden, and unfortunately, drug dealers don't say to you, okay, here's your heroin with fentanyl. All they want to do is stretch out the volume that they're providing. It's a supply and demand and a money thing. And what we're finding is that when we do harm reduction with our patients and we say, okay, let's go over your labs from the other day. Oh, did you know that your heroin or wherever you're getting it from is tainted with or adulterated with fentanyl? The patients themselves don't even know. So this is where the problem is worsening, is that you now have a very, very extremely vulnerable population that's already marginalized, an awful lot of homeless individuals, an awful lot of people with poverty, an awful lot of individuals with co-occurring mental health disorders. And now they're being given a substance. Most individuals, after an initial usage of heroin or an opiate, most individuals do not use to get high. I can say that, okay? They use so as they don't get withdrawals, and they now have no option in getting off this substance that they're addicted to. But now those individuals who are using the substance, okay, are being threatened with heroin that's now tainted with fentanyl, which is nearly lethal.
Rosemary.
Yes, so thank you for your presentation this morning. Could you describe what your interface is with the behavioral health unit at Bartlett and its subsidiary at Rainforest Recovery?
So yeah, we interface very closely with Rainforest Recovery, with Bartlett. The problem is that they didn't reopen their doors, okay, until about March 1st of this year, to allow patients to come in. The great thing about it is that they are giving priority to Juno-based residents, okay, but there is more of a need than there are beds, unfortunately. They have also opened their acute medical detox area that they can bring people in. to stabilize them, because medically some of these patients are very compromised. It becomes more of a problem with alcohol use disorder, which we've seen skyrocket as well. And we can do outpatient alcohol use disorder treatment, and Rainforest has been helping with those patients. There is a severe lack of psychiatrists, mental health individuals, counselors, therapists, substance abuse in Juneau, Ketchikan, and actually throughout the state of Alaska. And we do try and refer every single patient out for counseling, because medication-assisted treatment is only one part of this puzzle. Most of the individuals that we deal with have what we call adverse childhood events, ACEs. Nobody goes out and says, you know what, I really want to spend the rest of my life using drugs. Okay. Most of the time, individuals are using drugs to mask another symptom, another problem that has happened. A lot of my patients, majority of them, have suffered from some form of PTSD, some sort of childhood event, parents that have been incarcerated, generational drug usage, and where you have kids now that are coming up that just have to break that particular cycle. So we work really, really closely with members of the community. In actual fact, I'm going back to school at UAA starting in May to get my psych mental health nurse practitioner certification, because I'm internal medicine and addiction medicine. I don't have a psychiatric certification, because we're severely lacking in the community. We have no count. And then when you also look at the fact as well that there are counselors there, but they're completely full, and or they don't accept Medicaid, or they don't accept self-pay, or these individuals don't have the money to pay, you know?
So if I can just follow on with that, Bartlett is currently actively recruiting for 3 more psychiatrists and for a pediatrician with psychiatric specialty. And one of the things that we found during the pandemic, when things were closed down, and of course we had, in the middle of all of this, we were rebuilding the whole rainforest recovery operation. I mean, the building had been demolished and was being rebuilt. But one of the things that we did find was when they used telemedicine for counseling appointments and everything, that the show up factor was greatly enhanced. When people didn't actually have to come in and show up in person, they did come in, were much more compliant using the telemedicine option. So you're right, it's been a rough ride, but I think are working really hard to rectify some of the problems that you described.
Yeah, and I think ANTHC actually spoke to that point as well when they gave public testimony, and I gave public testimony as well to the legislature regarding House Bill 76. Okay, and ANTHC said, listen, this is one of the great things about the pandemic, is that we were able to access providers throughout the state, and out of state, okay? And part of the modified House Bill 76 that's going through right now, it's actually it just came out of the Senate Finance Committee. Part of the changes to that was to allow access to providers outside of the state, and so they would also get paid as well. That the insurance coverage would also pay.
Yeah, right.
Providers. So this is, if there's anything that came out of it, it just shows that telemedicine does work. And that people, the anonymity factor, as I mentioned earlier on, is also a really, really good thing. Juneau's a very, very small community. It's also very hard to get individuals to go to NA or AA meetings here, because they go to an NA or an AA meeting and they're sitting beside a neighbor, and they're afraid that their neighbor is going to talk to a friend of a friend of a friend, So the anonymity factor of being able to do, even 12-step meetings, or to do therapy and counseling online is actually a good thing,
Yeah.
Dolores,
Well,
this is Doug. What is the cost to the state at this point? And are you seeing an elevation of new users instead of just users that are chronic?
I mean, we see new users all the time, but unfortunately, what I see, so when we induct a patient and we take a patient in, I do a really, really thorough history and physical. And I'm going to give you the breakdown, and this is it for 90, I'm going to say for 90% of the patients. I'll say to an individual, when did your drug use start? And they'll say 2021. And I say, no, when did you start using any substance at all? Okay. And this is the pattern. I started using weed at home at the age of 13. Okay. I moved on to maybe alcohol with my peers at 14, 15. I was introduced to opiates at the age of 15, 16 in school with my peers. And then around about the age of 18, I couldn't find or afford the pills anymore. And therefore I switched over to heroin. And then they have this pattern of going into treatment. So even though they're new users in terms of opiates, okay, there is definitely a 7 or 8 year pattern there prior to them seeking treatment for opiate use disorder. So, and unfortunately as well, it's when they find that it's become a huge, big problem, or a near overdose, or a friend has overdosed, we see a real knock-on effect as well. When an individual in the community dies from an overdose, we see a little spike in people coming in and seeking treatment. So I hope that answers your question.
It does. What do you think the cost to the state is for this?
So just one second. I'm going to try and pull up this fact sheet here, and I'll try and share my screen with you here. Okay. So I'm just going to share my screen with you, and this is. So this is a fact sheet from, and this is from last year from Ideal Option. I requested that they take a look at the numbers that we were seeing, and this was through July of last year, just to show you. August of 2018, we were seeing fentanyl positive rates for toxicology in Alaska of 2%. By July of last year, 2019, and this is just, 4 or 5 months into the pandemic, we already saw that spike to 11.9%. Nearly 12% of all of our toxicology was coming in positive for fentanyl. We already knew and were tracking this. We actually have a specific fentanyl team, because treating fentanyl it's slightly different to treating heroin in terms of, mechanism of action, because of the half-life. It's got a much longer half-life than heroin. We were seeing 40% methamphetamine rates, horrible methamphetamine problem. I came from Florida. I never saw methamphetamine. Methamphetamine is a West Coast thing. Crack cocaine is an East Coast thing. So I saw an awful lot of crack cocaine in Florida. I also saw flocka and bath salts and MDMA as well. And gabapentin rates were 10%. But in terms of what the cost is to the state, okay, for patients who are getting into treatment, okay, and this is for our patients that are seeking treatment for Hep C, for example, okay, we can save the state between $10,000 and $46,000. In addition to that, state of Alaska, and we've actually gone to DHSS and we've gone to the state, okay, because right now, the state of Alaska, Medicare, Medicaid is paying for a fee for occurrence, okay, as opposed to a bundled rate. And what we're showing is bundled rates work much, much better. You do a capped rate per patient, and they get the full gamut of treatment, and labs are covered, etc. Right now, we're doing a fee per occurrence, which is very, very expensive. And we've actually gone to the state and given them and provided them with a better model, a bundled rate model. Unfortunately, again, with the pandemic, the things are very, very slow. DHSS is looking at splitting their department. We forwarded the information to Adam Crum, who's the head of the DHSS, and asked him to take a look at this, because we do want to save the state money, in terms of treatment. So I hope that did that answer your question?
They're not the actual cost of treatment?
I'm sorry?
The numbers that you just presented there, that's patient savings?
That's patient savings. Yeah, I'm sorry. I can get you the cost per treatment. I can, but
Fine, that paints a picture. Who
It's
else?
very high, very
it's
high.
very high. It's very, very high.
Who else has a question? Candy Barons has a question.
Since, and you touched on this a couple of times, there's a tremendous comorbidity between mental health issues and addiction issues. Mental health, those medications, it takes a long time to get proper cocktail, if you were, of medication or the right medication for an individual, say that's bipolar or schizophrenic. A lot of those guys are really resistant to medication because of how it makes them feel. But what my question is the drug that you have now to treat an addiction disorder, is that compatible with the mental health drugs?
Yes, it is. And that is actually one of the great things too, is that now we do have to be very, very careful in terms of what we call central nervous system depressant effect. So for example, Suboxone will cause some central nervous system depression, meaning the patient will get fatigue and tiredness, especially when they started as they're stabilizing. But yes, it does work with antidepressants, with the SSRIs. We do not like stacking these drugs. So for example, anybody who's on benzodiazepines, we don't like them being on massive amounts of benzodiazepines. We don't like them being on alcohol as well as a central nervous system depressant. So we don't like individuals, and we will screen for these things as well in their panels. We're very, very clear with individuals, with patients, as to what they can and can't take. And we have a really, really good rapport with primary care providers and other providers in the community. I'll always get a release of information to speak with other providers about what medication. We had a gentleman, an older gentleman, 60 plus years old, older in terms of my population, because I'm close to that too. So, but an older gentleman who was on multiple medications for major depressive disorder. Also, he was on some medications for some medical issues, and we worked with his primary care provider at Valley Medical, and we also worked with his primary care provider at JAMI to come up with the safest possible plan of care for this patient. One of the great things actually about the state of Alaska, which I really like, is that Medicaid actually has a requirement that if I'm prescribing, actually, it's also if any other prescriber is prescribing. If I'm prescribing Suboxone to a patient and they're on another central nervous system depressant, that also includes medications that are not controlled, things like gabapentin would be one of them, Flexeril, muscle relaxants, which are not controlled substances. State of Alaska actually requires that I have a plan of care on file, and I document that I've made a call out to the other prescriber to say, hey, we're prescribing this, you're prescribing that. Can we work together for a very, very safe plan of care for the patient? And that is actually a Medicaid requirement. They require that. They also require you to have like a taper plan if an individual is on benzos. So they require you to have those things on file. That's very, very different. That's not required in Washington or Montana or Florida or a lot of other states. So yes, we work very closely to try and come up with a very safe plan of care for the individual, especially when they're on other medications.
I've got a question from Eric.
Earlier in your talk, you mentioned there were 90,000 overdoses in 2019. Is that what it was? I heard 90,000. I'm assuming that's just for the state.
No, that's for the US. So between September of 2019 and August of 2020, the initial estimate came out that there was 81,000 overdose deaths. That number went up to, they've revised that number as of March to 90,000. And that's throughout the entire US.
I just wanted to clarify that.
Yeah,
So,
that's a horrific number.
so yeah,
I believe we have time for one more question. Rosemary?
so when you consider that 90,000 as the number of people you weren't able to save, what is the percentage, what does the 90,000 represent in the way of percentages of the number of people who are treated? That, I think that's the number that we, you know, really need to know about.
Yeah, I mean, I think that if,
I mean, the 90,000 represents the number that the medical profession was unsuccessful in trying to save. And what is that, what's the total amount then that we're looking at? Are those numbers available?
I mean, yeah, they are available. I would have to look.
I mean,
them up. I would have to.
that's where the real, I think that's, to me, that's an even more important number.
I think as well, one of the things to look at too is getting Narcan into the hands of the right people. How many of those 90,000 individuals had access to Narcan? I mean, we had the RX Opiate Summit was last week. One of the recommendations that they came out with is that any individual that's coming into you, especially as a new patient and starting treatment, when you prescribe Suboxone, you prescribe Narcan. And that hasn't been a prescribing rule, you know, but now that's what they're saying is when that individual comes in the door, make sure that they and their family have access to Narcan.
And I don't know if it's still the case since the COVID pandemic, but I always found it very, very concerning that it was our librarians who had to be trained to administer these drugs. Because so many homeless people who were addicted were hanging out in the libraries to stay warm.
Correct. And what we were trying to do as well was, and I'd spoken to what was previously Juno Opioid Work Group, and what we also came up with was maybe we should get this into the hands of bartenders, because they see an awful lot of overdoses in the bathrooms of bars in Juneau. In addition to that, taxi drivers, because taxi drivers are driving around at 2, 3, 4 o'clock in the morning, and they're the ones as well that come upon or see, you know, individuals who are on the street at that hour of the night. Front Street Clinic, or not Front Street, the Glory Hole. Now we've given kits to the Glory Hole, and they have them there available because that's where an awful lot of the homeless population also congregates. And then in addition to that, just getting it in the hands of individuals, you know, who there was a move last year prior to the pandemic of actually having staging sites throughout Douglas and out of Oak Bay, the Valley and downtown, where there would be Narcan, where there would be the Project Hope kits, where individuals could just go, you know, the way you can knock on a glass and get a defibrillator in some areas, and you pull out the defibrillator and use it on somebody. So there was discussions last year about doing that again by the pandemic, unfortunately.
Well, twice in the last year, I personally observed people in a very serious condition in the restrooms, the women's restroom at Fred Meyer.
Yeah.
It was very, very frightening.
Yeah, and I'm sure that over at Fred Meyer or over at Safeway, because there's in-house pharmacies, those pharmacists have Narcan kits.
All right. Dolores, I'd like to thank you very much for coming in today and talking to us about this. Thank you for all that you're doing for the people in our state.